Good evening, everyone, once again. I hope I'm audible to all. My name is Dr. Sally Gitugi, an anesthesia registrar at the University of Nairobi, and I'll be your moderator for the evening. I'm excited to have this opportunity to moderate the evening and share in the topic with Dr. Demet Sulemanji and Dr. Idris Chikophe, our speakers, both of whom are very passionate in critical care. This event is sponsored by MSD, and we're going to have a short presentation by Matthew Buloma from the representative of MSD. As we start, just before we start, I'd just like to ask for some housekeeping or etiquette. Kindly mute your microphones and stop your videos so that we can allow maximum bandwidth for our speakers for a better or enhanced experience. If you have any comments or questions, kindly reserve them to the end of this presentation where we'll have a Q&A. And in case you have something, raise your hand and myself and the administration will be able to get back to you. The first speaker of the day is Dr. Demet Sulemanji, who's going to be discussing on ICU liberation. Dr. Sulemanji is a consultant anesthesiologist and a critical care specialist, currently the head of the critical care services at MP Shah Hospital, Nairobi. She has joined our community after her 8-year career as a faculty Department of Anesthesia, Critical Care and Pain Medicine at Massachusetts General Hospital and Harvard Medical School, Boston, Massachusetts. She is an internationally recognized scholar with interests mainly focusing on mechanical ventilation and perioperative ICU appointments, perioperative ICU care for cardiac surgery patients. Her other academic appointments include faculty at the Department of Anesthesia and Critical Care at the Baskent University, Ankara, and Director of Clinical Research at Neurosciences Institute at Penn State University, Hershey, Pennsylvania. We're grateful to have you today, Dr. Demet. Kindly put up your presentation and you may begin. The floor is now yours. Thank you.
Thank you, Sally.
Thank you, Dr. Demet. We have your presentation and it's clear and you're audible. You may begin.
Thank you once again, Sally. Good evening, everyone. Thank you for joining us on a Friday evening. I hope to keep the topic light so we all have a good start for the weekend. Just give me a second. I have no conflicts of interest regarding this subject. So I'll be talking about ICU liberation, and here is how we are going to go about our topic. We'll start with surviving ICU. We need to start with admission to ICU. Who are we admitting to our units? Is there a patient selection criteria, accounting in the expected outcome? Or are we looking at the functional status of our patients, their disability scores? So in my opinion, ICU liberation starts with the decision of admission to critical care, actually. However, that discussion is really long and I think we'll save it for another day. So I'll start with surviving ICU and we'll continue with post-critical care syndrome. A little bit of introduction about this syndrome, because you know, there are a variety of presentations. So I want to just go over it before we even start talking about ICU liberation initiative. We'll talk about a little bit about the PADIS guidelines, and then we'll talk about ICU liberation bundle, and then we'll conclude our evening. So surviving ICU, when we look at it, you know, traditionally, our focus of critical care has been on reducing short-term mortality. You know, despite an increase in the incidence of critical illness syndromes, such as severe sepsis or ARDS, improvements in supportive care have resulted in improved survival over the years. So there's a study who actually looked at these numbers, and of approximately 6 million adults admitted to ICU in US each year, more than 80% survived, which is incredible. So as more individuals survive the critical illness, the acuteness of the critical illness, the clinicians are challenged with the task of managing the consequences of those who are surviving the ICU phase. So as we know, critical illness may result in long-term physical and neuropsychological dysfunction, and it is really costly. And there's also an ongoing healthcare utilization involved. So although some survivors return to their pre-critical illness level of functioning and health, many others experiencing lasting impairments in cognition, mental health, and physical health or quality of life. So any new impairment in one or more of these areas is called post-intensive care syndrome. There is a really good graph. I really like this. I took it from a textbook, ICU textbook. It actually, the top border here, let me go there. The top border here represents the perfect health, and the bottom border here represents the death. So the blue line you see is a healthy individual without any critical illness, and the blue line itself represents the life trajectory of this individual. So we go from perfect health to death, and this is the trajectory we follow. If someone experiences a critical illness, here look at the red line. There's a stage A, which represents the pre-critical illness, and then there's a stage B, which represents the acute phase. And then if you look at the C, like there are 4 different options. C1 actually goes back to almost normal and follows the trajectory, but only in a worst health status, but it is parallel. C2, as you would see, is a slowly progressive worsening health status. And C2, if you look at it, is relapsing. So there are ups and downs, ups and downs. These patients we see often in our units over and over again. And then there's a C4 trajectory, which is rapidly progressive. So the patient after the ICU discharge in a short while dies. So all these C trajectories are part of the post-ICU discharge life for our patients. And as you can imagine, C2, C3, and C4 is our focus today. That is where we are discussing our PICS post-intensive care syndrome. So what does it entail? Like, how do we see those patients? You know, the syndrome may come as a cognitive impairment. The patients may come with a cognitive impairment, a psychiatric sequela, a neuromuscular dysfunction in the form of, for example, polyneuropathy or myopathy, critical illness associated morbidity. This is relatively a new concept, as well as this chronic critical illness. And then, of course, low quality of life. And there is one more addition, that is the family of the patient. It's not directly the patient themselves, but their family is affected a lot as well. So we are going to go through them a little bit. But while you're following me, I want you to focus on the associations, the links, the risk factors that are, you know, putting our patients, leading our patients to experience these syndromes. So when we look at the cognitive impairment, ICU survivors after their discharge may have memory deficit, an attention deficit, or a concentration deficit. So Whether it's memory, attention, or concentration, most likely depend on the nature of the insult and its treatment, as well as the presence of any pre-existing neurological abnormalities and individual characteristics such as age or comorbidities. Well, this statement I just said is, what we always believed. So I just underlined most likely because we are not sure now what it is. What is it underlying reason to cause these people to experience these cognitive impairments? I got you a couple of studies, which I'll share with you just now. The first one is this one from JAMA, 2010. It's a longitudinal cohort study in older adults who had no premorbid neurocognitive impairments or dementia. They were assessed for their neurocognitive function prior to and following acute care or ICU hospitalization. So what they have found is individuals hospitalized for acute illness had a greater decline in neurocognitive function and new incident dementia than those not hospitalized. These findings suggest that acute or critical illness causes an abrupt decline in neurocognitive function, which is not due to premorbid neurocognitive problems. I think this was a reality check for us. We always thought, oh, if there's something pre-course, pre-ICU care, that patient is more likely to have those things. But, there are other studies confirming these similar findings, that they're not related. So this study is also from JAMA, same year from October. They used the existing patient data from the health and retirement study, which followed more than 27,000 older Americans for whom neurocognitive function was assessed both before and after severe sepsis. Patients with severe sepsis developed new, substantial, and persistent neurocognitive impairment. These guys concluded factors associated with acute or critical illness may be causally related to the neurocognitive decline in older critically ill patients, but they couldn't. What they couldn't conclude was why. Another study, similarly in NAGEM 2013, reported, but this time it's not only the older population, it's a broad case mix of ICU survivors. They had important neurocognitive dysfunction comparable with mild dementia or moderate traumatic brain injury 1 year after their critical illness. This is significant. This cognitive disability was present across all different patient groups, not related to age, not related to any other characteristics of the patient group. Another study was suggesting that unfavorable neurocognitive sequelae are not related to illness severity scores, age, smoking, or alcohol abuse. So for example, in critically ill ARDS survivors, neither length of ICU stay, Apache scores, duration of mechanical ventilation, or range of tidal volume, nor days receiving sedative, narcotic, or paralytic medications are associated with neurocognitive impairments. This was also interesting. So after all these studies, the statement done by the critical care specialists was this one in blue. The etiology of neurocognitive impairments is likely due to various factors that interact dynamically with pre-existing and genetic variables to produce adverse outcomes. So to make it short, there is no known defined underlying pathophysiologic or other causal mechanisms. Possible suggestions, yes, there are many in the literature and you may recognize them, include hypoxemia, it's always blamed, cumulative use of sedatives or analgesics, hypotension, delirium, hypo or hyperglycemia, both sepsis and inflammation. When we look at the psychiatric sequela, it may present clinically as a depression, anxiety, or post-traumatic stress disorder. I'm sure you have experienced any of them with your patients. When we look at depression, the data says, the incidence of clinically significant depression is around 28% in ICU survivors. Similar to cognitive dysfunction, acute illness severity at ICU admission did not actually predict the development of post-ICU depression. So when you look at other few studies, one of them, for example, says presence of early post-ICU depressive symptoms was a strong risk for subsequent depressive symptoms. Another suggests post-ICU depressive symptoms were associated with substantially lower health-related quality of life, which is significant because think of the gap here. We can actually address the lower health-related quality of life to decrease the number of patients who are experiencing depressive symptoms. Also, compared with the population with general critical illness, post-ICU depression was more pronounced in ARDS patients. This is interesting. And the risk factors associated with depression in this group included longer duration of mechanical ventilation, length of ICU stay, hypoglycemia, and cumulative sedation use. Anxiety has a similar story. Although alcohol dependence, female sex, and younger age were identified as risk factors. And there was an interesting one in this study by Hopkins. The predictors of anxiety at 1 year in ARDS patients actually were found to be the PF ratio. The lower the PF ratio, the high likely the anxiety is, and the duration of the mechanical ventilation. The longer of the longer duration, the higher the risk of anxiety. PTSD was also very common. Similarly, it was found with a prevalence rate of 28 in a cohort study with 80 ARDS survivors. There was a meta-analysis of prevalence, risk factors, and prevention treatment strategies for PTSD symptoms in our survivors. That also reported significant PTSD symptoms, but they gave the incidence about 1/5 of survivors at a 1 year follow-up. So patients with underlying psychiatric morbidities, benzodiazepine use, or early memories of frightening ICU experiences, this is interesting, had the highest prevalence of PTSD. When we look at neuromuscular dysfunction component of post-intensive care syndrome, the number one dysfunction is ICU-acquired weakness. It's very common with ARDS patients and other complex critical illness patients, regardless of the disease process. Muscles and nerves are injured. So that results in prolonged mechanical ventilation and, unfortunately, poor functional outcomes. There was an interesting study in New England Journal of Medicine, 2008, by Levine and friends. It was really interesting because they actually got diaphragm muscle biopsies from brain-dead organ donors who were on ventilators for about 18 to 69 hours and compared those biopsies with the ones they got from the control group who were undergoing elective surgeries, and they were on ventilator around 2 to 3 hours at a max. So what they found is, the muscle injury started within hours of mechanical ventilation. And if you have a chance, just look at the pathological images in that study. You will see a significant injury even on day 1 of mechanical ventilation. So they actually highlighted the concept of continuum of weakness that begins with this muscle injury within hours of mechanical ventilation and may persist with incomplete recovery for years after ICU discharge. Another version of neuromuscular dysfunction that we experience after ICU patients are discharged is polyneuropathy. It primarily manifests itself as a mixed sensory motor neuropathy. This is very common in patients with sepsis, with a prevalence of, yes, I didn't do an error, it is 70% to 100% of longer ICU stay patients. It is a lot. It affects the limb and respiratory muscles. Facial muscles are not usually affected. The limb involvement, when you see the patient, is symmetric and most prominent in the proximal muscle groups and mostly in the lower extremities. So when they looked at the pathogenesis of why the polyneuropathy is happening, they actually linked it to a perturbation in the microcirculation, and that will eventually cause an axonal injury and degeneration. And there's also evidence for a disruption of nerve action potentials. Another study showed hyperglycemia as a risk factor, and the tight glycemic control has been shown to reduce the incidence of polyneuropathy in critically ill patients. The exact pathophysiologic link between glucose control and neuroprotection remains unclear still, but may involve preservation of mitochondrial functioning, calcium homeostasis, or modulation of nitric oxide production at the cellular level. So earlier suggested associations between neuromuscular dysfunction and the use of neuromuscular blockers have not been demonstrated by recent data. Association between glucocorticoid use and weakness still remains controversial. However, in a study, a prospective multicenter trial in acute lung injury survivors, they reported a significant association between mean daily corticosteroid dose with impairments in physical outcomes after 1 year. So the higher the steroids we used, the more likely the weaknesses were. The last concept I'm going to touch on neuromuscular dysfunction is critical illness myopathy. The incidence varies between 48% and 96% in prospective studies that have included muscle biopsy as part of their diagnostic evaluation. So here muscle biopsy is a must because the presentation is almost the same with the critical illness polyneuropathy, and the patients may be indistinguishable from those with the polyneuropathy. So muscle biopsy is definitely required for differential diagnosis. The clinical presentation is patients appear weak and paretic, and they are usually difficult to wean from the ventilator. So this myopathy is pathologically characterized by a diffuse non-necrotizing myopathy associated with fatty degeneration of muscle fibers, atrophy, and fibrosis. So this has specifically been described in patients with sepsis and in those treated with corticosteroids and neuromuscular blockers. So here, as I repeat, the polyneuropathy was not found to be related with neuromuscular blockers, but myopathy has been in several studies. So as I mentioned, this is a relatively new term, but it is part of the post-intensive care syndrome. It's critical illness-associated morbidity. So majority of sepsis survivors is either diagnosed with a new health condition or has worsening of existing health conditions. So the studies showed persistent inflammation or a procoagulant state seen during recovery from sepsis may actually increase the risk of cardiovascular disease. So it may present as an MI, stroke, or maybe the need for coronary revascularization may arise. Also, as a new morbidity, we can see diabetes and atrial fibrillation in those patients, septic patients. So why is that happening? Like other than our assumptions of persistent inflammation or procoagulant state, we don't know. It's a complex disease, as you know, with a variety of potential mechanisms to explain how different aspects of sepsis and the ICU care of septic patients may drive late morbidity. It is also unclear whether other acute illnesses share similar pathways to cause these late complications. We don't know. This is also a new definition, chronic critical illness as part of the PICS. Patients who survive their initial acute illness, but consequently experience persistent organ failures, necessitating prolonged intensive care, meet the definition of this state. So they are usually characterized by high hospitalization costs, frequent acute care use, and poor long-term survival. The clinical and financial burden of this state is expected to increase globally in the next couple of years because there's an aging population and advances in the early management of critical illness results in more long-term survivors. So, quality of life really matters. Whatever I've counted so far, each of these outcomes may affect the quality of life. Approximately a third of survivors of sepsis hospitalization at 6 months, they have significant impairments in various domains of quality of life. The impairments in cognition and physical function may persist. They may actually lead to problems in mobility and performing activities of daily living and disability. Although many sepsis survivors return home, approximately 1/3 require additional help at home or are in a skilled nursing facility, an acute care hospital, or a rehabilitation facility. There is a term you may see, and it's PICS-F. F is coming from family. You know, so far we have discussed about the patients, but the family is really is an important part of this picture. A majority of ICU survivors who received long-term mechanical ventilation required the assistance of a family caregiver 1 year after their critical illness. It's such a long time. And providing such a care may result in PTSD, emotional distress, depression, anxiety, and it reduced the health-related quality of life for the family. In addition, caregivers experience significant burden because of a patient's physical and psychological dysfunction, and this lifestyle disruption associated with the challenges of managing complex care at home. So, what's the way forward? What will we do about these problems experienced by the patients and families after their ICU discharge? So SCCM, Society of Critical Care Medicine, came up with this initiative about 2 years ago. And the initiative aims, number one, to improve patient outcomes after an ICU stay and reduce the risk of long-term consequences from an ICU stay. Number two, to liberate patients from the harmful effects of pain, agitation, sedation, delirium, immobility, and sleep disruption in the ICU. So among the harmful effects mainly is PICS, the post-intensive care syndrome that we have been discussing about. So this initiative actually is aimed to empower the multi-professional team to provide care in the ICUs using two important tools, which are the number one, PEDIS Guidelines 2018, and two, ICU Liberation Bundle. So let's have a look at them. So when we are talking about the PEDIS 2018, it was originally published in Critical Care Medicine in September 2018. It is actually a roadmap for developing integrated, evidence-based, and patient-centered protocols. The original paper is 49 pages, so I'm not going to go over everything and anything that they are talking about, but in a nutshell, I'll give you what the objective is. So it's actually this 49 pages includes updated evidence-based recommendations for managing 5 issues. affecting nearly every patient in the ICU. There are recommendations, actually 37 actionable recommendations, 2 best practice statements, and 32 ungraded statements. Because we don't know what we are dealing with really in details, we don't have enough data. Those recommendations, most of them are not strong recommendations, but either moderate or low recommended suggestions. If we look through these 5 issues, actually PEDIS stands for those 5 issues, as you will see as we go through. Number 1 is pain. I use these summaries, the nutshell explanations from the authors, from the author's own summaries, because it's really a complicated paper. So these nutshell information that you're gonna see is basically directly from the authors. So about pain, these guidelines call for a protocol-based approach to both pain assessment and management. They include specific recommendations regarding the use of non-opioid analgesics, and they also include a multimodal pain treatment approach, and that's an important strategy to reduce the opioid use in hospitalized patients. Other recommendations address non-drug approaches to pain management, including massage, music therapy, cold therapy, and relaxation techniques in ICU. Second issue, agitation and sedation. Here, light sedation is recommended over deep sedation for most ICU patients. Propofol or dexmedetomidine is recommended over benzodiazepines in patients requiring continuous sedation. And there's a statement regarding physical restraints. It says, although physical restraints are commonly used, evidence to support their use is very limited. When we move to delirium, the recommendation is to use multi-component non-pharmacological interventions to reduce modifiable factors for delirium. Medications, including antipsychotics, are not recommended as a routine strategy to either prevent or treat delirium. And dexmedetomidine is conditionally recommended for delirium in mechanically ventilated patients when agitation precludes weaning or extubation of the patient. In 2013, these guidelines were actually published as PAD guidelines. So there are 2 new components in 2018, which is immobility, I, and S is for sleep. So about immobility, rehabilitation and mobilization interventions were recommended in the guidelines to reduce ICU-acquired muscle weakness due to immobility. And they actually have given us starting and stopping criteria for rehabilitation and mobility in the paper. So I just put a table showing that data. I don't expect you to see the details, but I just put it to show like how many different components are there, deciding whether today's the day we start rehabilitation or not. As I said, is for sleep disruption. Multi-component protocols are again recommended to promote sleep in critically ill adults, including control ventilator modes and nocturnal strategies to reduce ICU noise and light. The control ventilator modes, don't take it wrong, it's only for the night, for the person to sleep comfortably. Recommendations regarding the use of medications to improve sleep, like melatonin, for example, they were not able to be made. So we have the guidelines, but how are we going to implement them in our units? So SCCM has come up with the ICU Liberation Bundle. In other words, it is called ABCDEF bundle. Interestingly, this bundle has been published in 2017. even before the PICS guidelines. But after the updated guidelines, they were incorporated together. And now it's part of the ICU Liberation Initiative. Actually, I put here, this site that you are seeing is taken from SCCM website. The website provides numerous free resources, and there are a lot actually related to bundle implementation, including those ones specific to each bundle element. So if you decide to start implementing these bundles in your units, please have a look at the site. It has amazing resources. If we just have a bird's eye view look to the to these A, B, C, D, E, F bundle, you'll see it's basically touching similar concepts, but you'll see it's more of implementation oriented. So when we look at A, for example, it says assess, prevent, and manage pain. Use scales to assess pain, ensure adequate pain control, use regional anesthesia and non-opioid adjuncts, use analgesia-based sedation techniques with fentanyl. So in summary, it says stop the pain first and then plan for your sedation technique. B stands for both SAT and SPTs. We need to perform both of them in a linked way and daily. Multidisciplinary coordination of care needs to be there, and faster liberation from mechanical ventilation. C is for choice of sedation. So if sedation is not necessary, do not sedate. That's the recommendation. But it emphasizes targeted light sedation when necessary. Avoidance of benzodiazepines. Again, Dexmed if there's a high delirium risk, or if the patient had a cardiac surgery, or we are weaning from mechanical ventilation. D is for delirium. Again, assessments by certain scales, CAM-ICU and ICD-SC. Non-pharmacological intervention is promoted, including sleep hygiene. Dexmed or antipsychotics if there are hyperactive symptoms. E for early mobility and exercise. Physical and occupational therapy assessment needs to be there. Coordinate activity with SATs or periods of no sedation, and progress through range of motion, sitting, standing, walking, and daily activities. F is again for family engagement and empowerment, reorientation, provision of emotional and verbal support, cognitive stimulation, participation in mobilization. They can help us walk the patient down the hall, for example. Participation in the multidisciplinary rounds. It's also important to inform them, update them several times a day, maybe. If I know sometimes it's challenging, but as much as we include them through the ICU care phase, I think we'll have more gain after we discharge the patients. So we have all these bundles and the guidelines, and application of this bundle actually has been being practiced for the last 2 years effectively. And there are several publications which is evaluating the efficacy so far. And actually, I found this in the SCCM website, which has compiled all the publications so far about the implementation of this ABCDEF bundle. I want to leave this on screen for a few seconds because it's amazing. These numbers, if you have a look at them, there is 72% decrease in the next day mechanical ventilation. That means early weaning from mechanical ventilation. 65% decrease in the next day comas, 46% decrease in ICU readmissions of that patient, 68% reduction in hospital death within 7 days, 63% reduction in the next day of physical restraints, and 40% decrease in the next day delirium, and 36% decrease in likelihood of being discharged to nursing home and rehab facilities. I think it's amazing. I think we need to start looking into how we can implement those guidelines and bundles in our environments to whatever extent that we can. So I'd like to conclude. My conclusion number one is it is time for change. Our ICU survival rates are undeniably better. Quality of life upon ICU discharge is very low. So I think it's time to change our goals of ICU care from discharging a patient alive to discharging a patient with minimal damage and with a high quality of life expectation. Conclusion number two, we don't know. We don't know what the underlying pathophysiologic mechanisms are for PICS or why patients are experiencing other long-term effects of ICU care, or who is more prone to these effects. We don't know. We need extensive research and more data. But we know one thing, and it is how. So we already started working on how we can improve post-ICU care outcomes. Despite limited data, cumulative patient care experience and collective educated assumptions have enabled this critical care community to create a roadmap and a care bundle to at least minimize harm to our patients during their ICU stay and liberate them back to life. We can get a start from there. Thank you. Thank you, Sally.
Thank you so much to Demet for that wonderful presentation. I'm sure in a few minutes or seconds, we'll be seeing praises from the rest. Hands are being clapped. Thank you. At this point in time, I'd like to recognize the presence of our new participants. As we're preparing for the next presentation by Dr. Chikophe, just a quick reminder, kindly mute your microphones and stop your video sharing so that we can have majority of the bandwidth to our speaker. And we will have a question and answer discussion at the end of the presentation from our representative from MSD. So Dr. Chikophe, I see your presentation is already up. Apart from just introducing you as a passionate caregiver in intensive cares and anesthesiologist, there's not much I can say because apparently I would be lying. So thank you, Dr. Chikophe. It's your turn.
So thank you, Dr. Sally, for the frank introduction. So I'm
Dr. Chikophe.
The use of can you hear me?
Yes, now we can hear you.
Sorry about that. So I said I'm going to talk about the use of neuromuscular blockers in the intensive care unit. And just like Dr. Demet, I do not have any conflict of interest to declare. These are a lot of pictures that I'm going to show. And this is the outline of my talk. So I will go ahead and introduce the topic. So basically, neuromuscular blockers are some of the drugs that you use on a day-to-day basis in the intensive care unit. There's a very large application of these pharmacologic agents. Some of the applications are actually straightforward when it comes to decision making, but quite a number of them, there's a lot of debates that surround the decision at that point. So their use actually remain very controversial, all right? But I think the most commonly application for neuromuscular blockers is endotracheal intubation. We use it on a day-to-day basis to facilitate regular intubations and even for patients who have difficult airway. Because of course it tends to, increase your, improve your view during laryngoscopy. And if the view is better, then there's no struggling and there's reduction in airway trauma, especially to newcomers who are starting their career in intensive care medicine. Majority of us working in sub-Saharan Africa, and especially in the villages, in the rural areas, we use succinylcholine. It's a drug that gives us very fast onset of action, and the duration of action is ultra short. So even if you're struggling with the airway, the patient will reestablish respiration. There's the modified rapid sequence intubation from rocuronium. You achieve optimum intubating conditions in about 60 to 90 minutes at a very high dose, but there's the danger of prolonged apnea, and so you must have an antidote, which you can use after around 3 minutes of inability to intubate or to ventilate such patients. All right, so. But we can also use neuromuscular blockers to facilitate mechanical ventilation, especially in the group of patients that suffer from acute respiratory distress syndrome. And now that Dr. Demet has talked about ICU muscle weakness and how difficult it is to liberate patients who have had, muscle paralysis, which is something that we do on a day-to-day basis. One of the studies that I'm going to make a reference to is the study by Papazian and his associates. This is actually a randomized controlled trial whereby they had 2 arms of patients. In one arm, they were paralyzing patients who were presenting with moderate to severe acute respiratory distress syndrome. Okay, and in the other group, they were using, just deep sedation, okay? And what they were looking at basically was the outcomes in terms of how these patients were behaving, or maybe the, survival in the 90 days. And there was really no difference between the cis-atracurium group and the group that were actually managed on the usual way without sedation. But however, when you look at the level of the incidence of barotrauma, it was less in the cis-atracurium group compared to the placebo group. And also there were fewer pneumothoraces, okay, in this group. And you find that in this study, at least 50% of the patients were actually nursed in the prone position. So we would say maybe the application of neuromuscular blockade will be very useful in patients who you want to achieve a specific end. Like if you want to prone a patient with a severe or moderate to severe ARDS, you may want to do it, again, using neuromuscular blockade, all right? I'll go to make a reference to another study called the ROSE trial. Again, they were looking at patients who presented to the intensive care unit with mild or moderate to severe acute respiratory distress syndrome. And again, these patients were grouped into 2 arms. In one arm, they were given neuromuscular blockade and deep sedation. In the other group, they were just given light sedation. So what was the primary outcome, for example, in this study? You find that, again, there wasn't so much difference when it came to survival, to ICU discharge. But then again, when you look at other secondary outcomes, you find that, again, they didn't find a big difference in the incidence of ICU-acquired illness or weakness in the intensive care unit. They also found that there was a difference in the amount of, barotrauma, pneumothorax. However, when you look at the p-values, they're not really different. In the neuromuscular blockade group, they were using very deep sedation. So these patients were also having important cardiovascular events like hypertension and bradycardia. And also, again, when they looked at the muscle weakness, which they were using the Medical Research Council score, there was really no big difference. However, only 16% of these patients were prone, as opposed to 50% in the previous study that I made reference to, right? And in this study, there's a bit of confusion because there was a lot of crossing over. The patients, quite a number of the patients in the treatment or in the neuromuscular blockade arm had their neuromuscular blockade stopped much early, as opposed to, and also when you look at the other arm, quite a number of patients were actually put on neuromuscular blockade. Right. So basically, what can we conclude from these two trials? The evidence is actually very confusing. You will do a neuromuscular blockade maybe to achieve a specific goal. All right. So what does neuromuscular blockade do to patients? Of course, it makes them passive. It makes them paralyzed, and there's very minimal interaction with the mechanical ventilator. There's been advocacy towards, early spontaneous breathing. It is very, very important because, number one, it maintains your muscular tone. If you don't use your muscles, then they actually become atrophied. And then again, it may become very, very difficult to liberate this patient from the intensive care unit. You know very well that the maintenance of your functional residual capacity is actually due to a balance between your chest wall to pull outwards and your lungs to pull inwards. So at the point where they balance, that's where you maintain your functional residual capacity. So the use of neuromuscular blockade will actually make you lose your muscle tone, which will lead to generalized atelectasis. We have seen this after maybe paralyzing patients who had moderate to severe ARDS. As soon as we put them on neuromuscular paralysis, they go into more atelectasis, and the PF ratio may actually worsen, and it may take a very long time to go to the pre-paralysis levels of your lung mechanics. It therefore means that when you paralyze a patient, it means your ventilator requirements may actually go up. You may have to use maybe a formal lung recruitment protocol followed by an appropriate PEEP selection. All right. But what about spontaneous breathing? So during spontaneous breathing, of course, we try and generate an initial negative pressure, okay? And that pressure basically is in your pleura. Okay, so the pleural pressure goes down, then the ventilator will actually learn that the patient wants to breathe. So they either assist the patient or support the patient. So there's an initial drop in your intrapleural pressure, and then followed by pressure support or pressure assistance from the mechanical ventilator. So what has been shown is that when a patient is breathing spontaneously, then the pressure that is needed to expand the lung is higher than when a patient is breathing in a passive mode. So that's the difference between your plateau pressure and your pleural pressure, what you call the transpulmonary pressure, increases. And sometimes it can be very exaggerated when this patient has inappropriate respiratory drive. How do you measure transpulmonary pressure? There's a lot of work being done, and there's now the use of esophageal manometry. There's a balloon that is put in the lower esophagus, And the pressure there is actually very close to your pleural pressure. So if you do your plateau pressure and then you subtract your pleural pressure, you get a very good surrogate of your transpulmonary pressure. Okay, so in normal physiology, your airway opening pressure is around 760 millimeters of mercury, and your pleural pressure is -4 millimeters of mercury. So your transpulmonary pressure is around -4 millimeters of mercury. But then sometimes when we present to the hospital, we may have inappropriate respiratory drive. We may have very strong muscular contractions, which lead to an increase or exaggeration of your transpulmonary pressure. And what could happen is a syndrome called the patient self-induced lung injury. So how does that happen? Of course, when you increase your transpulmonary pressure, you generate very huge tidal volumes, which can give you strain and stress in the lung. Okay. Again, there's a concept called the pendulum concept, whereby if there's too much stretching, the well-stretched alveoli may actually start feeding into the smaller alveoli, something called pendulums, and you may get what you call inappropriate overdistension. It may worsen what we call the lung inhomogeneity. You may also increase your venous return when you make very huge tidal volumes, and so you increase your pulmonary blood flow. Your hydrostatic pressure in the capillaries actually goes up, and you get transudation, you get what you call pulmonary edema. But then again, if you make huge tidal volumes again, you may go into ventilator asynchrony, like double triggering or breath stacking. All these actually give you a syndrome called the patient self-inflicted or self-induced lung injury. So basically, this is a repetition of just what I have said. So when you are breathing using positive pressure ventilation, or you're on support and you're passive, you find that your pleural transpulmonary pressure is actually the difference between your air pressure and your pleural pressure. But when you give PEEP, your pleural pressure is in the positive direction. But where there's no PEEP, actually your pleural pressure is in the negative. So your transpulmonary pressure actually worsens. So it will be your airway pressure minus pleural pressure, which gives you a bigger magnitude in the negative direction. And what happens is that you get pulmonary edema, you get inflammation, which is part of the component of your self-induced lung injury. So how do we predict patient self-induced lung injury? We may want to look at how the patient interacts with the ventilator, for example. So there's a metric that is called P0.1. This actually measures the pressure generated by the muscles of this patient in the first 100 milliseconds, just before, in the pre-trigger phase, just before the patient takes a breath. The ventilator circuit sort of maintains an occlusion pressure, and that patient tries to breathe against a closed inspiratory valve, and you see the pressure drop. If the pressure drop is more than 2 centimeters of water, if the pressure drop is more than 4 centimeters of water, this patient has an exaggerated P0.1. And you could say this patient has a very high central respiratory drive, for example. For example, this is what really happens, because patients are supposed to not drop the baseline pressure by that much of a magnitude. If they do it, and you can obviously see it on the waveforms, and the minute volume of this patient is increasing, this patient has an increased central respiratory drive. For example, this is a young man we were managing in the intensive care unit. His predicted body weight was around 40 kilos, but you could see that he had a very high respiratory drive of up to 10 liters per minute. And then when we looked at his trigger, or his, the way he's dropping the baseline pressure, it was going all the way to the negative, okay? Our set PEEP was probably in the 5, but in the pre-trigger phase, this patient will actually drop the baseline pressure all the way to the negative. So his minute volume was expected to be around 4 liters, but he was actually doubling his minute volume. And so when we did the P0.1, it was way above 4. So you can say this patient has a very increased, P0.1, and such patients tend to have an increase in your transpulmonary pressure. If this patient was passive, the pressure that is needed to expand the lung would actually be the difference between 15 and maybe 5. But for this patient to generate a tidal volume, they'll actually increase their transpulmonary pressure. The difference will be maybe 15 and a 0, so it will be 20. So too much activity from the brain, too much muscular activity will actually worsen your transpulmonary pressure. And if a patient is already suffering from some mild to moderate form of lung injury, then they can actually make it worse. So we need to mitigate the patient's self-induced lung injury. Of course, some of the strategies that are needed to minimize this is, of course, appropriate use of PEEP. You want to index your tidal volume to your driving pressure, and of course, the application of your transpulmonary pressure. Of course, we can reduce the patient's respiratory drive by using neuromuscular blockade. I know the evidence says there may be increased incidence of neuromuscular paralysis, neuromuscular weakness post maybe intensive care stay, but appropriate use of neuromuscular blockers may actually prevent progression from mild to severe disease. Okay, so why do we use neuromuscular blockade? You may want to minimize your transpulmonary pressure, of course, to improve your patient-ventilator interaction, to improve your lung distension, to improve your double triggering, okay? And of course, in the previous studies that I've alluded to, some of them actually did bronchoalveolar lavage, and they found that there was less cytokine production from these patients who were paralyzed, all right? We are already using the P0.1, and also this measurement of your transpulmonary pressure. This is really, really big. And this is a patient who is likely to injure himself if we do not take care of the respiratory drive. Of course, deep sedation sometimes may even worsen your P0.1. So the best therapy may be use of neuromuscular blockers in some of these patients. Of course, we have other indications for neuromuscular blockers. If you want to optimize your mechanical ventilator, if you want to optimize your breath timing, especially in patients who are suffering from status asthmaticus, these are patients who have a problem with the expiration. They tend to have reduced airway caliber. And so the time that is given for them to expel the gas from their lungs is actually not enough. So for you to manipulate such patients so that they have a short inspiratory time and a very long expiratory time, you may want to do that maneuver when the patient is passive using neuromuscular blockers. Sometimes we may sedate the patients who have a very high intracranial pressure, and if they're still coughing, you may actually want to paralyze these patients. Again, the same can be used in very bad cases of abdominal compartment syndrome. And most importantly, when you have patients who have suffered what you call out of hospital cardiac arrest, and you're giving the targeted temperature management to prevent them from shivering and cause an oxygen demand supply imbalance, you may want to use neuromuscular blockers, all right? What are the adverse effects of neuromuscular blockers? Of course, most of these are related to your immobility, your DVT, your exposure keratitis, and of course, the ICU related muscle weakness, which is an obstacle to ICU liberation. The tensor tympani is a skeletal muscle, and it's also paralyzed. So paralyzed patients tend to be hyperacutic, and they can hear even when clinicians speak in low tones, and they may actually have very explicit recall of what was happening in the intensive care unit, all right? And this may actually worsen the occurrence of your post-traumatic stress disorder. Thank you for your attention, and these are my references. Thank you, Dr. Sally, for the opportunity.
Thank you so much, Dr. Chikophe, for that insightful and educative talk. I'm sure also people are gonna chime the same thing. Dr. Demet, there was also a lot of praise from the audience on the excellent and wonderful presentation. I'd now like to invite Matthew Buluma, who's the representative of MSD currently in Lignum Vitae Health. Matthew, if you can kindly put up your presentation, thank you. And in the meantime, to the participants, feel free to start engaging our speakers for questions, because the question and answer session will follow after this talk. Thank you. Thank you, Matthew. Your presentation can be seen very well.
Yes. So thank you very much, Dr. Sally, and Critical Care Society of Kenya for having us partner with you in this educational webinar. Yes, so my name is Matthew Buluma. I work for LVH, representing MSD for the anesthesia and critical care portfolios in Kenya. So I'll give a brief overview. I'll give a brief overview of our products that are involved in neuromuscular management. So at MSD, we have a neuromuscular blocking agent, rocuronium bromide, by the brand name Esmeron. This is actually the original neuromuscular rocuronium bromide. And we also have Bridion, Sugamadex, which is a reversal agent that is specific for either reversing a neuromuscular blockade that is induced by either rocuronium or vecuronium. And so with this unique combination actually provides you with an opportunity to have rapid and skeletal muscle relaxation, and also a very predictable and complete rapid reversal from any level of a neuromuscular blockade. So the benefits of using Esmeron to provide adequate relaxation cannot be overemphasized. I think most of the speakers have alluded to that. And basically, Esmeron provides you with this adequate induced NMDA-induced relaxation that actually improves your intubation conditions, thereby minimizing the injuries to the vocal cords, because you have a very good visualization of the cords. It also helps in the reduced pressure when you're dealing with the wound closure. And beyond intubation, there are several benefits that Esmeron will provide for your patient. So you will have a patient who's pretty relaxed, you reduce coughing, better wound closure, and in procedures that require a lot of stillness, like in the laparoscopic surgeries, you get very good relaxation with Esmeron. It also helps you to manipulate the doctor to manipulate the extremities quite easily because of this decreased muscular resistance. And so many start having good deep neuromuscular blockade actually helps you improve the surgical conditions. So you're able to improve the visual field and the muscle relaxation. The pain scores are also lower, and you use significantly lower morphine, and you have faster bowel recovery. So this should actually give you the confidence to use the appropriate depth of neuromuscular blocking agent, Esmeron, because you have the confidence that you have a product that can be able to reverse the effects of Esmeron at any depth should you require to do so. One of the benefit of Esmeron is that among the non-depolarizing and neuromuscular blocking agents, it has the fastest onset of action. So within 60 seconds, you are able to achieve adequate intubation conditions in the majority of your patients. Actually, some studies have put it that over 70% of patients achieve excellent intubating condition. Comparing it to the other non-depolarizing neuromuscular blocking agents that are available in the market, you get the most rapid onset of action with esmero. And due to this fast onset of action, esmero is the only non-depolarizing NMDA that is recommended for rapid sequence intubation. So for your emergency surgeries, you are able to achieve intubation conditions within 60 seconds if you use a higher dose of 1 milligram per kg of esmero. It also offers you a very flexible duration of clinical action. So if for your average 30 to 40 minutes procedures, and the standard intubation dose of 0.6 milligrams per kg should be able to give you a clinical duration of 30 to 40 minutes. Should you require a higher amount of time, you can go up to 2 milligrams per kg, and it will give you as long as 100 minutes of clinical duration. For shorter duration procedures, you can go and adjust, your dosage to as low as 0.3 milligrams to 0.45 milligrams per kg. So basically, esmero gives you a very flexible dosing options for your standard intubation at 0.6 bolus at 0.6 milligrams per kg. If you need to maintain the dose, the blockade, for example, when you already have a recovery of 1 to 2 responses to the twitch, TOF, you can be able to maintain your paralysis using 0.15 milligrams per kg. And also you can use it as a continuous infusion where you can use a dose of between 0.3 to 0.6 milligrams per kg of body weight. And so once you've used esmero or vecuronium to induce your neuromuscular paralysis, you have a product that can be able to reverse this action. So Bridion is a reversal agent that is specifically tailored towards reversing neuromuscular blockade that is induced by rocuronium or vecuronium. The molecular name is sugamadex because this is a sugar molecule that has a unique mode of action. So it basically encapsulates the neuromuscular blocking agent, thus reducing the amount of neuromuscular blocking agent in circulation. And therefore, because of this direct mechanism of action, you're able to achieve rapid reversal of the neuromuscular blockade whenever you need it. So Bridion offers you very predictable, complete and rapid reversal of your neuromuscular blockade, basically keeping you in control of your neuromuscular blockade management. So once you've achieved your neuromuscular blockade with either ROC or VEC, you can rapidly reverse that action using Bridion at whatever depth. So for example, in the unfortunate event, for example, that you're not able to intubate or to ventilate, you can be able to use Bridion at a higher dose to get immediate reversal within a few minutes. And you see, and you realize that there's a lot of variability in terms of patients' recovery time from neuromuscular blocking agents. And this could actually predispose the patients to complications that are associated with the residual block. And several studies have actually shown that over 90% of patients with with respiratory problems in PAC who had a residual block. So, and even in studies that were trying to assess the risks for ICU admission, they actually saw almost half of them was a result of respiratory problems. So actually the issue of residual blockade and neuromuscular management should be very key to critical care specialists. Bridion provides you with improved reversal of rocuronium-induced neuromuscular blockade as compared to neostigmine, which is our standard reversal agent. As you can see from this illustration, almost over 96% were able to recover from neuromuscular blockade at extubation with a TOF of over 0.9, and a significantly higher amount patients with neostigmine had residual blockade. So the reversal of Bridion is predictable. In case of diff blockade and you need to reverse your patient, you're able to reverse the patient within 5 minutes from a post-tetanic count of 1 to 2 to up to the ratio of 0.9, where you can be able to extubate, compared to neostigmine, which has a very high variability of the time to get a complete reversal. For the moderate block, you only need 2 milligrams per kg of Bridion to achieve a reversal within minutes. And the reversal with Bridion is complete. So the worry about residual blockade with Bridion is minimized. From this illustration, you can see actually over 97% of the patients in deep blockade were able to be reversed to a TOF ratio of 0.9 within 5 minutes, following the rocuronium-induced neuromuscular blockade, as compared to none in the neostigmine group. So for moderate block, the same trend, 98% vis-a-vis 11%. And reversal is rapid with Bridion. From deep blockade at a standard dose of 4 milligrams per kg, within 2.7 minutes, you're able to achieve full recovery from the neuromuscular blockade. In moderate blockade, within 1.4 minutes, at a dose of 2 milligrams per kg, you're able to achieve excellent recovery from neuromuscular blockade. Given the cost constraints with Bridion, it is not recommended for your routine reversal as a routine reversal agent. However, we recommend it for your special populations whereby you need very careful management of the neuromuscular blockade, where you want to achieve good, deep, good neuromuscular blockade and have the confidence that you can be able to reverse these patients from whatever depth of blockade at whatever time you want. So for patients, for example, your obese patients, your elderly patients, your patients with renal or hepatic issues, your cardiovascular patients, and patients with the pulmonary disease, these are examples of patients you should consider having Bridion on your table, just in case you need to use it and to manage your reversal of your neuromuscular blockade. And just to emphasize on the special patient population, for your pediatric patient populations, you get very rapid reversal, and it's comparable to the adults. Patients with cardiovascular disease as well. So there's the efficacy and the safety of Bridion has been proven in this patient population. So you don't get any increase in the heart rate or blood pressure. There was no reported instance of residual blockade, and Bridion provided complete reversal for neuromuscular blockade at 1.7 minutes and 1.3 minutes in your moderate and deep blockade respectively. So thank you very much. That will be the end of my presentation. And thank you very much again, CCSK, for having us partner with you in this educational meeting. Thank you.
Thank you so much, Matthew, for that presentation. I think it also serves as a very good reminder for use of Sugammadex. At this point in time, I'd like to open the floor to the question and answer session. Feel free to post your questions or to raise your hand, and we will have time to, yes, we have a few more minutes for a quick question and answer session. and also Dr. Chikophe. There has also been fantastic presentation, great presentation. Dr. Chokwe has said about the 10-set timpani and recall. Now that's something, so thank you for that, which is a very important reminder for us around the bedside of patients who are relaxed, that, you know, we can also encourage family to speak to them, and also to, while we're doing our rounds, to be mindful of their hyperacuity. So I'll just give just a few more minutes for the Q&A. Thank you. Thank you. Dr. Chokwe?
Yeah, good evening and thanks for that great presentation. You can hear me?
Yes, we can hear you, Dr. Chokwe.
There is a video going around of some patients with pulmonary dysfunction playing a violin. I don't know whether it's Dr. Chikophe or Dr. Sulemanji who can talk a few things about that particular patient. They are mechanically ventilated, intubated and everything, but they have fairly good mental.
Sorry, Dr. Chokwe? Hello, can you hear me?
Function. Hello?
Hi, sorry, Dr. Chokwe, we lost you just after you're talking about patient who can play the violin. Kindly please repeat.
There's something that's going around on the internet about a patient who's been intubated and on mechanical ventilation, but seated up and playing a violin, the like. So it looks like they have fairly good neuromuscular function, but they don't have good pulmonary function and require support. I don't know whether we reach that level of rehabilitation for our group of patients here. Did you hear me?
Yes, thank you. Dr. Chikophe, Dr. Demet, care to answer?
Yeah, maybe I could answer. Given the ICU liberation protocol, the liberation bundle, there's a component that Dr. Demet has mentioned of early mobilization. There's also, you see, like in our setting, we do not have like respiratory therapists, and you find that patients on the mechanical ventilator tend to be deeply sedated. A respiratory therapist actually would sort of trick the ventilator to ensure there's lots of comfort without having to deeply sedate a human. So they are more wakeful, they can move around, they're mobilizing. And yes, that is something that we aspire to have in our setting. Match the inspiratory flow, match the breath timing, match the trigger, and again, let that patient move as early as possible. Yeah.
Thank you for that, Dr. Chikophe. There's a question here in the chat box from Dr. Kevin Umani to you. How long would you recommend muscle paralysis in the initial stages or beginning of mechanical ventilation in ARDS?
So many of the studies have talked about between 48 to 72 hours, but you're supposed to do that intermittent breaks. So for example, you know, a lot of us are using these drugs that are non-organ dependent in terms of elimination from the body. But in other places where maybe the cold chain is a problem, they're using things like vecuronium, which tends to have cumulative effect. So instead of giving like a very long continuous infusion, some of them would actually do intermittent, so that now you paralyze a patient, then maybe early morning you stop the paralysis. If you don't have enough stimulator, then you wait for that patient to gain their muscle power and assess how comfortable they are on the mechanical ventilator. Of course, if the patient is on the prone position, you may want to not to stop any paralysis if they are still in the prone. But once they are on prone, you can actually try one or two things. So the recommendation is about up to 72 hours, but you could actually stop and see if the patient is interacting with the ventilator very well.
Thank you, Dr. Chikophe. Dr. Mani, I hope that answers your question. There are more people who appreciate the excellent presentations from the chat box, both to Dr. Demet and Dr. Chikophe. Considering the time is now 7:30 and there are no more questions or hands that have been raised, allow me to now bring this meeting to a close. I want to thank Dr. Demet again and Dr. Chikophe for the wonderful presentations. Matthew as well, thank you for the support as the sponsors for this presentation, and to each of you participants for being present. It's for you that we actually do this, and it's great to see so many people available on a Friday night to listen to this. And one thing that people used to say is when there are no questions, it means either you understood everything or you understood nothing. But I believe in this case, it was well presented. It's been my pleasure being your moderator for the evening, and I look forward to the next few presentations or CMEs that we're going to have in the coming year. I wish you all a safe and enjoyable festive season. Shelmith, thank you so much for putting all of this together in a timely manner and for the smooth work that you've done through all of this. So I wish you all a good night, and I believe it's now 7:32. You may freely leave. Thank you.